Associate Professor James Ward is the head of Infectious Diseases Research, Aboriginal Health, at the South Australian Health and Medical Research Institute in Adelaide. He's leading researcher in Aboriginal sexual health, blood-borne viruses, and associated issues including illicit drug use. He's currently leading research through a Centre of Research Excellence in Aboriginal sexually transmissible infections and blood-borne viruses, and an NHMRC Project Grant aimed at improving outcomes in Aboriginal and Torres Strait Islander communities around the issue of methamphetamines. So, and many more projects, I'm sure, but welcome, James.
Thanks very much, Rhina. Let me begin by paying my respects to the Nurrunga people for their custodianship of country, law and land here in Perth, in beautiful Perth. As a Pitjantjatjara Nurrunga man myself, I do this as part of custom, but as respect and acknowledgement of people's long, hard fought battles for repossession of land that was stolen from Aboriginal people in the early days. I should also acknowledge Uncle Mick Adams, who's just walked in the room. You thought you snuck in, Uncle Mick Adams, but somebody who's a very strong leader and advocate in particularly in Aboriginal men's health, and he's did his PhD on Aboriginal men's sexual health, and really has been a role model to me. So sorry Mick, you tried to sneak in up the back there, but good to see you, and I'll catch up with you after this presentation. So I thought I didn't really have any kind of instructions what to present today, so I thought I'd take the liberty to do whatever I wanted to do, and it's a bit of a mixed up presentation really, but I hope that you'll find it informative. And I really want to talk about 2 weeks in March that happened this year, and I'll tell you what those 2 weeks in March in a moment. Talk a little bit about STI rates in Aboriginal communities, because I think everyone knows that we've got very high rates of STIs and very disparate rates of STIs. Talk about the syphilis outbreak and what's happening with the response. And lastly, finish off with HIV in the issue of HIV in our communities. So firstly, 2 weeks in March was very reminiscent of 2007 actually, in the lead up to the NT intervention. And I actually thought mainstream media were on the same path about to send in an intervention into Aboriginal communities, because I'll show you in a moment what happened. But it started with this report, which is actually the 6th baby dying from the syphilis outbreak in remote Aboriginal communities in Australia. Now, as far as I'm concerned, no baby in this country should die from syphilis, but because of this ongoing outbreak that's occurring in the north of Australia and central Australia, the RACP, the College of Physicians, put out a press release, and the ABC picked it up and ran a story. When you run one story, a whole lot of other journalists come on board. And so this guy here, sorry, these two are out of order. But this guy here, Amos Aiken, he's a new journalist up in the Northern Territory trying to make a name for himself, really puts out some headlines. So this is the day after, on Monday the 5th, and puts out some headlines, child abuse like a tsunami. Remember, the first article about this is about the 6th baby dying from syphilis outbreak, which really was about a poor public health response in this country to syphilis. Then Amos again the next day puts another article in. He'd been talking to lots of Aboriginal leaders, and Aboriginal leaders of course say that all Aboriginal kids that are at risk should be in safe care, as I do. Any kid that's at risk in the Australian community should be in safe care. John Elfrink, a former member of the Parliament in the Northern Territory, is a former copper and a redneck copper in Alice Springs, writes a lovely story about STIs. All of these stories are linked to STIs and child sexual abuse. So John Elfrink chips in the next day in the Australian. And then finally at the end of that week, on the 11th of March, we rang our friend Michael Koziel, who's at the Sydney Morning Herald, who really started to look at the data and say, put a different balance and different angle on the story, that this needs some reality checks, that the high rates of STIs in Aboriginal communities are mostly reported in over 16-year-olds, and there is a minority in under 16-year-olds, which we'd been telling him. And he ran some stories, and they got subsequently picked up in other media over the weekend of the first week. Which way am I going? Then Prue and her little panel here on the Weekend Sunrise show really didn't hold back. Prue is the one with the lovely coloured, almost Aboriginal motif shirt there, I just realised. But she didn't hold back in saying that Aboriginal, we should have no qualms in the Australian community about creating another stolen generation. We should have no qualms about it because these children are unsafe and these STI rates are really abhorrent, and we should be, taking all these kids and putting them into white families like they did before. That subsequently caused a lot of protest by the Aboriginal community outside Sunrise. I won't go into how they tried to cover up the protest, but those of you who are following this story will know that Sunrise tried to cover up these protesters out the front of their studio. And then we found a great friend in The Australian. The Australian is the one that ran the original stories. So Amos Aiken works for The Australian. Then we found a great friend in The Australian. So I advise anybody who wants to talk to media and have a balanced story in Indigenous issues to contact Stephen Fitzpatrick at The Australian. He's been very good throughout this whole process. So Stephen Fitzpatrick really wanted to put some more balance, and he's actually saying, I want to give the other side of the story to Amos's story. So he kind of ran two stories and really gave the other side to Amos's story in The Australian, so that was on the Wednesday and the Thursday. And he also started to move the dialogue from this is a government failure rather than a community failure. He started to move the story that way. We wrote a story, we were collectively trying to get some data together. I wrote a story in The Conversation which went out the next day, and then eventually the journalist, another guy at The Australian, this Greg Brown, ran two stories. Firstly, he blamed Scullion, which he rightly deserves to be blamed for everything in the failure of Indigenous issues in Australia. So firstly he blamed Scullion, and Scullion came back very quickly to say, this is not me, I did refer it to the Minister for Health. And then Greg Hunt got flogged the next day in The Australian, so they moved the dialogue to the ministers. And then Dean Smith, our wonderful senator, Liberal senator for WA, if you don't know him, all of you living here in WA, you should know him. He's a very good champion of STIs and blood-borne viruses, very committed to getting things done for MSM and for Aboriginal and Torres Strait Islander people across the country. Wrote a very balanced story in The Australian the next day, on the Friday. Then I'm thinking, that's pretty good, that's all kind of moved. And then the next day I read The Australian at the Qantas Club, and then Angela Shanahan, she's a lovely woman, she's saying that we should bring back adoption for childhood kids. And then us three mugs, my two sisters there and myself, were on the television on Monday the 20th. So, and we gave the other side of the story. And actually, to be fair to Channel 7, they got a lot of pressure put on them by the AFL to run this alternative panel. They'd had protests all throughout the week outside their windows in Channel 7 in Sydney. And AFL put a lot of pressure onto Channel 7, so our Aboriginal leader at the AFL, Tanya Hosh, put a lot of pressure onto Channel 7 to run the story. Given that David Koch is the chairman of the best AFL club in Australia, and that I happen to follow, he ran the interview for us on Tuesday the 20th. So if you don't know the best club in the AFL, it's the Port Power in Adelaide. Yeah. Just to chime in there. So and so they ran this. They ran the alternative panel, and this is what it's really all about, really. So this is just data from the Northern Territory, and there's some lessons in this. So I don't know if you can read this. The 16 and over, you can see predominantly notifications of STIs occur in people aged 16 and over. That 98% of the infections in under 16-year-olds occur in 13 to 14 and 15-year-olds. Now 13 may be considered, some of these cases may be sexual abuse, and as I said before, any place where children are unsafe, they should be removed. So we don't know that all of these cases in 13 and 15-year-olds are sexual consent between similar age peers who happen to live in prevalent communities where prevalence of STIs are around a quarter of the population, and very likely to get an STI if you live in these communities and don't use a condom. So majority of these STIs occur in 13 to 15-year-olds, and there's a very few number of cases in 12-year-olds and under 12-year-olds, and those are far too early and very likely sexual assault cases. But really, they made this great big hoo-ha about sexual assault. They linked all the STI cases to child sexual assault. Median age of sexual debut in Australia is 15. That means people are having sex when they're 13 and 14 if you're white or black. It's slightly earlier if you're living in a remote community, not surprising given there's not much else to do there except admire the opposite gender or the other people in your community. But really they made a great big hoo-ha about it. And so really it put a lot of, I mean that's only a fraction of the media that occurred in that 2-week period. And really I thought all of this was leading up to an intervention, which is what happened in 2007. It was like reliving the experience of 2007 when they threw in the army into remote Australia to find all these cases of sexual abuse which haven't come to fruition. I'm not denying there's sexual abuse in remote Aboriginal communities. They've just had a 5-year Royal Commission into sexual abuse in institutions, which I've had the privilege in the last 2 days spending with Helen Milroy, who Aboriginal psychiatrist from WA, who sat on the Royal Commission for the last 5 years as one of the commissioners. And there's a lot of sexual abuse in this country, but our population gets singled out, and they get singled out because of failure of the public health system, which is where the story started in the first place, of a baby dying of syphilis in the first place. So really kind of takes me away from my work. It takes a lot of people's energy away from our work when media get this right. So there's really, I'm trying to say that there's nobody else in sexual health rarely, unless you work in in sexual assault, rarely has to talk about STIs in Aboriginal, STIs in their population and sexual abuse. Why don't we talk about STIs and how to fix up these STIs and reduce prevalence in these communities, rather than just labelling it all as child sexual abuse. So really took a lot of energy away from it. And of course there are many caveats around the data. All those cases of 13 to 15-year-olds may not be related to peers having sex with each other. There may be some cases in there that are sexual abuse. There are caveats in the data that not all sexual assault cases end up in an STI. So there are lots of caveats around the data, but to really put all of the emphasis on STIs and under 16-year-olds onto child sexual assault is really erroneous and does very much harm for our population, including not only for the people who live in remote, not even young people that live in remote, but actually downstream as well, in terms of trying to get people to come and work in remote. Now, people who are on mainstream Australia, who are sitting in Sydney and Melbourne and other places, they think these places are rampant with child sexual abusers. Why would any nurse in their right mind who wants to come and help Aboriginal communities want to go and live in these communities when we have media reporting constantly about this? Now, WA was on the brunt of this when they had 38 cases in under 16-year-olds, when they wanted, then a WA minister here a few years ago wanted to close down all remote communities. And that was reported in mainstream media as well. So you're not immune to it on this side of the country as well. So I think there's important issues for everyone in this room. Know your data and understand when they are reporting stuff like this that there are two sides to the story and that we need to get some balance in media. So those of you who work in the health department, I think it'd be very wise to have a watching brief of STIs that are reported in under 16-year-old, because these media issues do arise periodically over in mainstream media, and they're only ever directed at Aboriginal and Torres Strait Islander people. Let people know that the majority of STIs are in under 16-year-olds are probably likely to young people having sex with each other in very endemic communities for chlamydia, gonorrhea, trichomonas, and syphilis more recently. It speaks a lot to the failure of child notification system in this country, that's for sure. Health departments really need to be ready to feed people some data to talk against what's currently being reported. So I'm going to leave that, but I think that was I think it's important that STIs in our setting are often linked to a much broader discourse in the Australian media, and I think it's more reason why we need to do much better at trying to reduce STI rates in our population. So now to a not so positive story, and I've presented this data before, but it's really, I present this slide here because it's really indicative of what the challenges are that lay ahead in remote communities to try and bring these rates of STIs down. So this is a paper we wrote as part of the STRIVE study, Rebecca's paper. It was published in 2014. It was our baseline data, but what we looked at, the cohort of people who live in remote communities, what proportion of people diagnosed with one STI were diagnosed with other STIs in a single year. And you can see here, they're pretty shocking figures. 40% of young women are diagnosed with either 1, 2, 3 infections in any single year. So it's no wonder if you're 13, 14 and 15 and you have your first sexual debut at those ages, 40% of your peers having an STI in any single year, you're going to get an STI if you're not using condoms in communities. So really the challenges lay ahead, and for young blokes the co-infection rate is much higher for both chlamydia and gonorrhea. Very low rates of co-infection with trichomonas, given that trichomonas doesn't stick around as long in men as it does in women. But it really kind of sets out what the challenges are. And have a look around the world about who's reduced endemic rates of STIs in communities. There are very few groups who have managed to get it down. And we've been trying lots of different things for a long period of time. We've probably had $20 million in research grants that have tried to reduce these rates of STIs. It's frustrating as all hell, but there's an easy test, they're easily treated. We've had probably that amount of money, and we've got a whole lot of knowledge now. The reality is, how do we get these rates down? And so Rebecca's probably talked about Tango yesterday, the point of care test. We've tried CQI in communities. What it really will take is comprehensive programs, behavioural, biomedical and very good clinical care that will bring these rates down. And that's the key to all of this. And that's not easily achieved when we've got siloed buckets of funding to try and reduce STI rates in communities. So we did try and increase testing rates in remote communities with the STRIVE study. I'm not going to go too much into the STRIVE study, but we kind of moved testing rates up 40% overall, closer to 50% actually. We moved testing rates closer to 50% over a 4-year period using CQI as a standalone intervention in remote communities. It moved it up, but we started at a very low base. So if you moved it, so testing rates of young men that were attending remote clinics were at 14% when we started. By the time we finished STRIVE, 22% of young men that came to the clinic were being tested for an STI. 50% sounds great, but actually the absolute percentages are not great. And so what we need to do is move the absolute percentage testing rate in remote communities closer to 60 or 70% to be able to impact on community prevalence that exists in these communities. So really, and we had a lot of effort put into STRIVE. There was a lot of effort put into STRIVE to improve these testing rates. Lots of reports generated. People had access to their own data. People put in strategies based on what they thought were their weaknesses in their communities. And basically, we didn't impact on community prevalence at all with a 40% improvement in testing rate. It really shows that we've got a lot of work to do. Some other really key things that we found in STRIVE was retesting rates. So retesting after a positive diagnosis is in the guidelines. Probably you all should be aware of them as if you're working clinically at 3 months, around 3 months. But what we found was around 30 to 40% retesting at 3 months. This is people after they've had a positive diagnosis for chlamydia, gonorrhea, trichomonas. They were tested around 30 to 40%. And what happens, because we only get to 30 or 40%, is that we have a really high rate of repeat positivity in the same period. So around 30 to 40% of same people who've been tested, treated and repeat positivity, because we haven't got to a high enough level of retesting at 3 months. This is an important thing for an important outcome of STRIVE as well, in terms of making sure that HIV is on the radar for our people. So also guidelines say if you don't do a full battery of tests on the same day, you need to test for HIV within 30 days to make sure we can reduce transmission. If people have exposed themselves to an STI, they may have exposed themselves to HIV. Repeat or try and get people in within 30 days. And what we found in Strive is only a third of people were being tested for HIV within 30 days after a positive chlamydia, gonorrhea or trichomonas case. 6% were, or 26% of these were done on the same day. So only 6% were actually being done after the battery of STI tests without HIV. So we need to improve that so we don't end up in a situation like we have with the syphilis outbreak in remote Australia. We need to get on top of HIV. If it's present in remote, we need to get on top of it very rapidly. And this is one way I think we can do it, is to follow guidelines and make sure. I've still got 11 minutes on my time, so I'm not sure how you're working. I've got my own clock here, so 10 minutes, because I'm renowned for going over time, so sorry about that. So I just checked it just a minute ago, so sorry about that. What's your name? Sorry. Yeah. So make sure we don't get in the situation where we are with syphilis, is that we need to get on top of HIV testing as soon as possible. So the syphilis outbreak, I probably won't go into this too much, but really it's probably the worst example. I don't know, Donna Mack, do you find another example of the worst example, a worse example of public health response in Australia than this? Probably not. Yeah. I mean, you have an outbreak of berries, 31 cases of hepatitis A. The whole country knew about it. You have 6 babies die of this. Nobody knows about it except you guys in this room. Nobody knows about it. There's almost 2,000 cases of infectious syphilis diagnosed because of this outbreak, all epidemiologically linked, and which started in 2011 when Campbell Newman, the Health Minister and Premier of Queensland, dismantled public health and sexual health services in that state at the time. It spread from WA into the Northern Territory, into the Kimberley, and now into South Australia. Really appalling response, public health-wise, in this country, because they're young Aboriginal people living in remote. There are 2 worlds we live in. I'm not going to hold back on that. Most of those cases, if that had happened in a western suburbs, I always get the suburbs wrong across different cities, if that had happened in a western suburbs community here in Perth, there would have been alarm bells ringing, I can guarantee. If there was a syphilis outbreak in schools or in high school students or in university colleges around well-to-do areas in this country, there would have been a very different response. Sad reality. But after this little syphilis outbreak, which is now a mammoth outbreak, that we've all been monitoring very well for the last 5 years, monitoring where it's travelling to and the number of cases for the last 6 or 7 years, 2018, we've been monitoring it for 6 years at least. The government, the Commonwealth, have really started to put some traction into our response. Is that far too late? I'd suggest so, but 2,000 cases later, 6 babies, but at least they're doing something, and it wasn't because of a lack of advocacy, I can assure you. It wasn't because of a lack of advocacy. And they've allocated $8.5 million over the next little while. Unfortunately, they picked areas where probably syphilis outbreak is not so concentrated. So they picked, initially they picked Darwin, Townsville and Cairns instead of remote areas where the communities are really struggling and have least capacity to deal with syphilis. But after some strong advocacy in the last few weeks, they are moving it to Katherine West and East Darnham in the Northern Territory for a response. So it's a test and treat model. Rebecca's involved in this quite a lot in terms of rollout of rapid testing for syphilis. And they're really trying to increase workforce, roll out a whole lot of rapid tests and community engagement. So I'm going to just move quickly, even though I've only got 7 minutes left here. So quickly what we're doing, the Goanna study really is, it's Goanna 2, we're really trying to collect data, the second set of data from young people at community events around the country, and we are in the process of that now, so we've collected at 6 community events so far. We're aiming to get to 2,000 surveys collected to follow up from Goanna 1, which will give us an understanding of trends and what people know about knowledge, health service risk knowledge, risk and health service access for the Goanna study. We are starting a Centre for Research Excellence in Aboriginal Sexual Health. Well, it's not starting, it's just taken 3 years to get engagement, but we are working with 5 clinical hubs around the country, and what we're trying to do is a similar kind of surveillance network to the Access Network, which many of you may know about. The Access Network is a large collaboration of sexual health services data. What we're doing is working with about 40 Aboriginal health services to extract their patient management system data, give it back to them in a format which is, can be used for quality improvement and to draw other research questions from their own data. And so the hub that we have in Western Australia is in the Kimberley, South Australia, New South Wales, at Poona Pemba up in Cape York and Brisbane. And so we'll be able to do similar kind of analyses as the Access study does, but also to work very closely with the Access Network when they're up and running, because they're using the same data extraction tool called Granite, which is very useful. So when patients move between sexual health services and Aboriginal health services, we might be able to follow people in that way. So it's a way down the track. We've been doing quite a bit of work around health promotion in communities. So the Young Deadly Syphilis Free, so we've got a very big social media platform. I've got some other insights into social media in remote communities. We've been running these 2 television commercials out in remote for a very long, since the 1st of July last year, so we've finally got some money to let the community know. And they've been very, I think people know about them everywhere I go. They say, oh, I know the syphilis ad. So we've made some animations around syphilis. We've got a very good website now about that hosts a lot of resources for young Aboriginal people, predominantly targeted at young Aboriginal people, but also for clinicians working in remote. And we've got all of these kind of resources that have been developed over the last little while to help people working in communities with young people. If you're running education sessions with young people, they're in low literacy format and in ways, in a whole range of issues there for people to use, particularly those of you working with young Aboriginal people. So I haven't left much room for HIV, so I'm going to skip through quite a few of these, but the really bad news is, in a time when we've got the best medical interventions and the best biomedical interventions in this country for HIV, rates are going up in the Aboriginal and Torres Strait Islander population, more than double the rate of diagnoses than non-Aboriginal people. You can see there the bottom line, 2012 to 15, you can see the difference between the previous 4-year periods over the life. We used to have around 80 notifications every 4 years. Now we've really got the last period was much higher notifications. Currently we've got around 50 notifications happening a year. Unacceptable in this day and age. Median age of diagnosis very similar, but younger for our population. But there's a group of older people who are less people diagnosed over 40 for our population. Majority of notifications still occur among men who have sex with men, but only 50% of the notifications occur among men who have sex with men, compared to around 80% of non-Aboriginal people in this country. So very different epidemiological profile, much higher diagnosis among people who inject drugs, and higher diagnoses among heterosexual people when you compare it solely with Australian-born non-Indigenous people. Very different epidemiological profile in terms of where people are diagnosed, much more evenly spread between urban, regional and remote in our community. And not very much difference actually in terms of late diagnoses and advanced diagnoses between the two populations. Slightly higher advanced diagnoses, and this is data from the last 20 years, 96 to 2015. Majority of women diagnosed with HIV in our population occur because of heterosexual sex, but a high proportion of women are diagnosed in our population because of injecting drug use, much higher. Men, higher proportions of heterosexual and also IDU, but also MSM and IDU than compared with the non-Aboriginal population. I'll go a bit slower. Yep. But really that's what's happening with HIV in our population. And really, any of you working in HIV prevention really should be promoting all of these as what's in your toolbox for HIV prevention in our community. So Rebecca and I just quickly have been trying to develop a treatment cascade for Aboriginal and Torres Strait Islander people living with HIV, and it's been very difficult to say at the least how people are going in terms of diagnoses and particularly trying to get to undetectable viral load. So we've used two methods to try and formulate a diagnosis and treatment cascade. So the first one, we used some modelling work from the European Centre for Disease Control model, and then the access database for Aboriginal people living with HIV, where they are on the care cascade. And as you know, most of Australia is at the 90-90-90 level, 90% diagnosed, 90% on treatment, in care, on treatment and undetectable. But for our population, very different. So we've got much higher proportion of our population, we think, undiagnosed, 18% undiagnosed compared to 8%. But the really surprising one here is, firstly, there's a lot of people missing, which we've got to do a lot of work to try and find where Aboriginal people are, because what's not in here are Aboriginal people who are accessing general practice who are not in the access database. The Royal Perth Hospital, for instance, is not in this database as yet. So there's a lot of people, a lot of stuff we need to find, but there's a big group missing from the access database. But the thing that's surprising is that it's around 90, oh, my time's done now, whoops, stop, yeah. But I'm sure you can extend me just a few more minutes, yeah. I've travelled a long way, yeah. Yeah. The thing that's really surprising about this is that even the people that are in care and on treatment, many fewer are getting to an undetectable viral load. So 80% are getting to an undetectable viral load. And that is closer to 92% or 93% in the non-Indigenous population. So something's happening for even people who are on treatment, who even get on treatment. Most people who are in care are on treatment, but people who are on treatment are not getting to undetectable viral load. So they're either taking treatment interruptions, mobility, can't afford treatments at one point and go off them, exposure, stigma, all the kind of things we know about that probably are impacting on Aboriginal health overall are probably impacting for our population here. I won't go into them, but I will just promote these resources here. So we have been doing quite a bit of work around HIV health promotion, Facebook page, our website, atchiv.org.au, lots of infographics there for people to use as posters in clinics and so forth. We've got a PrEP animation, given that there were no specific resources for Aboriginal communities. We made a PrEP animation, a HIV animation, and I just want to acknowledge all my team. I don't do all this work alone, so there's a big team of us that work on all of this work. So thanks very much. So, have I got 10 minutes for this one? Which means 15, really. No, it doesn't. I better put my timer on because... so this is part of the Young Deadly Syphilis... Oh, no, not Young Deadly Syphilis Free. The Young Deadly Free project. We actually did a survey of remote area clinicians to understand what their professional development needs were or what they required in terms of education materials in remote communities. So the Young Deadly Free project is a large project. It's been funded by the Commonwealth. It was activity 6 of the 6 activities they funded, the Commonwealth. And ours is really trying to work with remote communities to improve clinical outcomes for people living in remote areas. So we had to develop some, so we said we'd develop a website. Oh, well, the Commonwealth wanted us to develop a website for remote community members because they all are on the website all the time, as we know. So we developed a website and we meant to be, and we're delivering clinician resources, a whole lot of resources for young people, and a whole lot of resources for people of influence, so teachers, parents, grandparents, people who are involved in the care of adolescents and young people in Australia. So it's on the Young Deadly Free website, most of this information. So we've been doing a lot of work, and the stuff I showed in the last presentation really as a result of Young Deadly Free and Young Deadly Syphilis Free. There's two separate projects, but we've melded them into one, basically, and really to try and get the word out there around things. But to the sexual health professional development needs of remote area clinicians, we sent out a survey, and we also got our regional coordinators. So we've got regional coordinators in WA, 2 in WA, 1 in the Kimberley and 1 in Perth that's working with remote communities, 2 in the Northern Territory, 1 in Central Australia and 1 in the North, 1 in South Australia and 1 in Far North Queensland. And so they facilitated some clinician groups in the start-up of the project to understand what clinicians wanted in terms of resources and how they wanted to be delivered in remote communities, people who work in remote communities. So we developed an online survey, we did some consultations, focus group consultations, and we asked people what they wanted. And this is who we got. We got 69 participants, I think. Was it 69? Or I think there's 69 participants, where the majority of those were female remote area nurses, which is predominantly who works in remote communities. 21% of our feedback were from health workers. 70% were from non-Aboriginal people who work in remote. And very few, most people had worked less than 1 year in remote communities, which is very characteristic of remote practice, really. And then we had 24 focus groups with remote area clinicians. And sorry, this is a busy slide. This is Amanda Sipasado's presentation that she's supposed to be presenting, so I'll dob her in. But she double booked today. So we asked people what did they want in terms of new resources. And you can see there, I don't know if you can read that from up the back, but really the predominant areas where people want assistance with is assisting patients to prevent and manage STIs. They wanted lots of information about mandatory reporting. Contact tracing was the next area. So opposite gender, so you can think, if you think most remote area clinicians are females and you're working with young men, obviously there's some issues there around working with different gender in these cross-cultural settings. Now people, Belinda and others may have different views that we should be just testing and treating everyone the same and not worrying about these gender issues. But really you can see the top 4 or 5 issues there: cross-cultural sexual health discussions and testing, and follow-up testing, I think, as well. So some of these we are able to develop in terms of developing these into resources. Others it'll take other agencies to develop. So we're on the process of trying to work out these. And in terms of blood-borne viruses, what do people want? They want more knowledge about how to interpret results. The second one is follow-up testing, assisting patients to prevent and manage blood-borne viruses, treatment. Particularly, I think this must be in the context of hepatitis B, but also HIV. Mandatory reporting, again, features in the top 5 or 6, and contact tracing as well. So there's obviously some needs for sexual health, for remote area clinicians in the areas of STIs and blood-borne viruses, and some of those are very similar about how to help patients manage and prevent STIs. Mandatory reporting, contact tracing seem to feature in the top 6 for both STIs and blood-borne viruses. Unfortunately, we're not funded to develop face-to-face training, but that's how most remote area clinicians want their training to be delivered. 70% of them want their training to be delivered face-to-face. And secondly, they thought videos featuring clinicians would be a good idea that work in remote. Written resources for health professionals on the campaign website would be useful, 48%, but overwhelmingly people want face-to-face training who are working out in remote in the areas of STIs and blood-borne viruses. So we've got a whole lot of stuff. We tried to combine everything together in the clinicians part of our Young Deadly Free website. So we've got some videos up there from doctors, nurses and health workers who are talking about issues of the importance of syphilis testing, for instance. We've got some. We've tried to pull all together the clinical guidelines and the practice manuals for remote Australia, all in the one spot. We've got some fact sheets about mandatory reporting and sex and the law, even for young people. I mean, you think about sex and the law in the previous presentation. Do young people in remote community understand what their legal requirements are around sexting, around who they're allowed to have sex with and who they're not allowed to have sex with, and when they're going to be mandatory reported? Probably not. Most Australians probably don't know that. But given there's a younger age of sexual debut in remote, then maybe we need to start promoting these messages more broadly with our population. They're a sample of some of the videos we've got on our website, so if you haven't seen them, they're short videos. They're really between 3 and 7 minutes. We tried to make them engaging for clinicians, so we've got remote area nurses there, remote doctors, and Amanda is taking control of a whole lot more filming of people across different settings. So the feedback we got back about our resources was that, particularly from places like Far North Queensland, around the syphilis ads, where they're the people from down south, they're not our mob. And so what we're going to try and do now is film in all these different locations and then combine them into videos so that people can't say they're not our mob. Then we have people from different areas involved in the same videos. So they'll all be finished by October, and there'll be a whole lot of stuff. So based on what young people and also clinicians have told us, we're trying to fill the gaps in resource development. So there you go. I've finished 2 minutes early. Thank you very much, Chair.
Save any questions on that until